Okay. Hello and good evening, everyone. My name is Sydney, and as Chief Executive of the Australian Institute of Health Executives, it is my absolute pleasure to welcome you to our introductory webinar tonight. Very pleasing to see so many people able to join us for our first webinar. Now, AIHE is obviously a fairly new initiative, and it was founded on an aspiration and commitment for authentic collaboration with you in your healthcare roles and with your teams to understand your unique contexts and your unique challenges in order for us to design customized training that is actually practical and relevant to you in your healthcare roles. In terms of the AIHE difference, what sets us apart is that we use an interactive case study approach that's based on actual frontline experience by healthcare leaders who are currently practicing in this space. And you'll see that tonight throughout our presentation. So we specialize in providing professional development, health sector analysis, and expert consultancy services that are bespoke for healthcare leaders, that's specifically designed and delivered by practicing healthcare leaders. In terms of tonight's session, there is a Q&A function that will let you ask any questions at any time throughout the session. We will see if we've got time at the end to open it up for a broader discussion. And throughout the webinar, you'll also see interactive questions pop up on your device, your laptop or phone, whatever you're using to dial in from, and you'll have the opportunity to input your responses into that. And on that note, I'd like to introduce and hand over to our Chief Academic Officer at AIHE, Professor Luis Prado, who has over 30 years of experience in clinical governance in public and private health services across about 3 jurisdictions, who will lead tonight's session. So welcome and thank you. Luis? Hi, Luis.
Hi, thanks very much, Sydney, and welcome everyone, and thank you very much for the introduction, Sydney. And to all of you, thank you for joining us tonight. It's great that you could come along with AIHE in our journey, and particularly our first webinar where we deliberately have chosen a topic that we think will resonate with you. How do you know your hospital is safe? And if you're not working in a hospital, how do you know that your health service is safe? In Australia and indeed around the world, there has been many cases, unfortunate cases, of significant patient harm, including death. And when those cases have been looked at, when the systems have been analysed, the people involved, the board directors, the executive, the clinicians, have asked themselves, how could this happen? How could this happen when our hospitals are accredited by a regulatory agency? We've passed all the compliance questions. How did we not know that there was a problem in this area? Yet that occurs, and in Australia, every single significant clinical governance failure has occurred in an organisation fully accredited by the state regulatory authority, by the Australian Commission of Safety and Quality in Healthcare. And those who have been involved have difficulty sleep at night, thinking about what they could have done to prevent that harm. What was their responsibility? Why didn't they know it wasn't safe? And for those who watch from the periphery in like organisations undertaking similar roles, asking themselves, how can I be sure that where I am is safe? How do I know that my hospital is safe? And so tonight we'll be looking at some of the practical strategies and insights that we can use to actually undertake an analysis of how you know your hospital is safe. How would you, in that space, work out what's required to undertake a safety analysis of where you're working? And AIHE has developed 4 key components to our program that assist us in determining what is safe. And here they are. We're committed to the improvement of practical clinical governance, actionable in everyday practice at our hospitals, clinical governance that transcends from the theory to the actionable to improve patient care and demonstrably so. we've developed a program called patient-centric incident management. And patient-centric incident management is novel. It comes, of course, from the concept of patient-centric care, but extends beyond that to when things go wrong. We'll look at open disclosure and why open disclosure, when it was first established in this country, we led the world in transparent and open dialogue with patients when things go wrong. And yet, despite nearly 20 years in practice of open disclosure, it still has failed to resonate in the safety and quality sphere at the level that we had all hoped. And finally, our data-driven decision-making in clinical governance to move from what is the touchy-feely to the real hard-nosed decision-making based on real evidence, real data that can make change and convince those that we need to convince why that change is necessary. So the first thing we'd like to do is just ask yourself a question, if you don't mind participating with this, about who you are and what your role. So we'll put that up on the screen in a moment. Excellent. So we can see we've got a range of participants in both clinicians, clinician leaders, executives, and consumer patients, which is a very interesting spread. So thank you for that. And in terms of, do you think your hospital environment is safe? Interesting spread. I think it's safe, but we probably could do better. And some people admitting they don't really know and they hope so, or they lie at night worrying that it isn't as safe as they could be. So thank you very much. We'll go on to then how we frame how you know your hospital is safe and looking at the key areas of analysis in clinical governance that we at AIHE do when we're asked that question to come and have a look at a system. There are many things you can do. There are many aspects of clinical governance you can look at. You can be inundated with frameworks, templates, policies, procedures, previous data, the list goes on. But in our experience of years of looking at clinical governance and where clinical governance has failed, I believe these are the key 5 areas of focus. Whilst it might seem straightforward, and while it might seem indeed somewhat mundane, the clinician scope of practice and how that's determined at a hospital, healthcare service is critical. Because done well, clinician scope of practice ensures that the right people, the right doctors, right nurses, right allied health, with the right skills and training, the right qualifications and the right experience, assessed by their peers and provided by referee reports to be competent and clinicians that can be trusted, are working on the right equipment, undertaking the right care on the patients that they should be caring for with predictable, good outcomes. Where the clinician scope of practice is done as a process of just compliance, where it fails to align with the clinical outcomes of the hospital, where it fails to protect patients from clinicians who shouldn't be practicing in a particular area, then the clinical governance system fails immediately. So assessing a clinician scope of practice and how that's undertaken is a key part of knowing if your hospital's safe. If you're a board director and executive, even if you're not working directly in this space, it is important to know how it's undertaken in your hospital and to what degree the clinician scope of practice aligns directly to and is visible to the staff who are looking after the patients on a day-by-day basis. Do they know that the doctor who's coming in to undertake the procedure is able to undertake that procedure and to do so safely? The next step is the mortality review process. Yes, everywhere has a mortality review process. But we talk about patient-centered care. We talk about the person and the individual and the importance of them as a patient. Surely the most important thing that we do at the end of the care, if they've died in our facility, predicted death, planned death, palliative care death, or an unexpected death, regardless, is our obligation to review that death and to ensure that the death that occurred was one that was either not preventable or was provided best care, or if it was preventable, what could have been done. The adequacy of the mortality review process and its incorporation of a multidisciplinary approach, its incorporation of transparency in the discussions, and its incorporation of benchmarking is critical to assessing the clinical governance of your organisation. Patient-centric clinical incident management, which I mentioned a moment ago, is focused on openness and transparency. Assessing your clinical incident management processes for openness and transparency is key in determining whether it's safe. Everybody does clinical incident management. Everyone does clinical incident review. But to what degree those reviews inform change, inform improvement, and are fed back to the patients and their families is indicative of the culture of patient-centred care and patient-centred care when it goes wrong. The degree of openness and transparency can be assessed very easily. Ask yourself the question, does the patient and or family get a copy of the incident report when it's completed? Or do they get what you believe is what they should be told? Some form of subtracted information from that report because you don't feel you can provide it to them. The next step is the conduct of clinical outcome analysis review. And you see, I've got conduct there in inverted commas because clinical outcomes are analysed and reviewed on a regular basis in all organisations. We're required to do so just by the national standards. But how are they done? Are they done in morbidity meetings where all clinicians from different types of clinical backgrounds are able to discuss cases? Are they part of a process of improvement where the teams come together and look at both good and poor outcomes? Are they done in a manner of transparency where people feel comfortable and able to express their concerns? Are they done in a manner where benchmarking internally and externally is welcomed? And most importantly, are those outcomes provided in a meaningful way, both the executive and the board, if you're thinking through the governance process, and back to the team of clinicians who are providing care, and indeed the patient and the community. And the final section I think that's most important in determining if your hospital is safe is what is the actual culture of safety. No, I'm not talking about whether or not you've got a culture of reporting. That's okay, it's commendable, but it's whether or not patients' incidents will be escalated by clinicians. Do they feel comfortable to escalate concerns, and do they know that they will be acted on? Have you asked your clinicians, your workers and your teams whether or not they feel that the hospital they work at is safe, and do they feel that they can actually escalate concern? So we'll ask you the next question and see what your thoughts are in this case. So they'll come on the screen. This is about culture of safety questions. And this question specifically asks, what happens at your hospital if someone falls at 2 o'clock in the morning? I use that example when I conduct seminars and webinars with clinical managers in particular. And it's interesting to put in the room the clinical managers with the non-clinical managers of the same facility and ask that question. The clinical managers will respond very similarly to what we've saw tonight. There'll be some who think we should call the patients from next of kin pretty much as soon as it's feasible. Others who will determine to do so based on clinical criteria, if there's been any harm, if there's been any injury, or other circumstances. It varies. It varies. But interestingly, when we ask clinical non-clinical managers of the same facility when they think the next of kin could be called, invariably they have the same response. They all believe that next of kin should be called pretty much when the patient is comfortable and stable and they're able to be called. And it's an interesting cultural variation because the decision is usually left to the team leader or the clinician, when in fact, what our non-clinical managers tell us is this decision should be actually one of the patient, and it should be focused on the fact that when harm has occurred, even if the harm is minimal, even if the harm is minor, it should be considered that the next of kin should be called. And this is about your tone and culture of patient safety in your hospital and what is expected. Now, I challenge you to go back and see whether or not in your facilities, your managers are all in alignment, and or indeed where there is what we've found in normal context, significant variation in when that call is made. So in our next slide, we're looking at the practical clinical governance that I've discussed as a key part of the AIHE program. There is enough theory, online courses, there's enough papers, there's certainly multiple frameworks on what clinical governance is. But I suggest to you, go back to your facility and ask clinicians on the ground, those who are working with patients, whether or not they actually understand what clinical governance is and explain how clinical governance lives within their clinical team in the provision of care. Because it's so often disjointed to what care is, how care is provided, clinical governance doesn't even resonate in many clinicians as something that's meaningful to them about how they practice, more about how they have to comply with a set of rules. Many people understand what clinical governance is about in the safety and quality space, but we fail to act. In the cases I described earlier of clinical governance failures in this country, it's not because people haven't known what's required, it's for failure to act when something's happened. And that is often due to the fact that we've been so compliance-driven, so focusing on passing a form of accreditation, providing information to another agency, getting that thing done in 30 days, that we forgot that the focus should be on the outcomes. The outcomes for patient results, patient care. And then ultimately, we've thought this through carefully at AIHE and seen that there's a spectrum of how clinical governance is enacted. From a clinician-centric, which is what I do is good and what care I provide is excellent, across to patient-centric, which is the clinical governance program is in place to keep patients safe. There's lots of well-intended people, well-intended programs, multiple business cases that have been produced to try and improve patient care. But the failure to produce data and back our programs with data, what we want to change, what we've measured that, how we've measured that change, and what that change has meant both from a safety perspective and a financial perspective has held us back in clinical governance. So the key component of practical clinical governance I've just touched on is the patient-centric clinical incident management. It's something that we feel very, very strongly about at AIHE. And patient-centric clinical governance is about bringing our patient-centric incident management to the forefront and drives how clinical governance is enacted in our facilities. So what do we mean by that? Well, incident management, which has been around quite a while now, has actually varied from one end of the spectrum, which has been the clinician stating, and you'll have all heard of this, well, no matter what we've done, the patient outcome wouldn't have changed. Often, the patient death would not have been preventable. Yes, we could have done things better, but the patient outcome would have been the same. That's clinician-focused incident management. The clinician determining that the outcome is unchangeable and to reassure themselves that what's happened was unavoidable. Most of us have moved to what I call compliance-centric incident management. And compliance-centric incident management is about, yes, we know we have to do these things. We will do what's required. We'll pass all the compliance tests. We will knock the tick in the box for every aspect of our incident management. We'll have our report within 30 days. We will have sent the notification to the coroner. We will have done the things that's required of us. However, when we track back those things, we find that little has changed in the delivery of care. The Queensland coroner, about 4 years ago, stated, how is it possible that he had seen multiple clinical governance reports of maternity complications, including death, all describing the same failures in systems, all describing improvement programs that were going to be in place, and yet he consistently sees over and over the same reports coming in from the organisations, the same factors being found in terms of the errors that have occurred. So if we can move on to the next slide. And so patient-centric incident management is about that commitment and engagement with our patients and involving them in the whole process from the very beginning. We're convinced that that's very important in AIHE, that they need to be involved from the very beginning through, let's take the RCA as an example, or the London Protocol Review, all the way through to the very end, where there's been meaningful change enacted, that the changes and outcomes have been focused on will deliver improvement, and then that improvement we're committed to. So a subset of the patient-centric and clinical incident management is contemporary open disclosure. And as I said earlier, in Australia, open disclosure was the world leader in this transparent dialogue. But after 20 years, it hasn't resonated in the manner that we all thought it would. I think we failed in even its terminology. Open disclosure does not resonate as a term with patients and their families. It suggests that everything we did before the open disclosure was hidden, that we're forced to tell the truth, when in fact it should be a continuous dialogue. So as part of patient-centric incident management, it means that open disclosure isn't a tick in the box in the incident report that was completed, but is an ongoing component of patient-centered care, and it's delivered in a timely way and a continuous way throughout the incident management investigation and through the process of resolution of that incident with the patient and their family. And it has to be delivered in an authentic way. And it's critical that the clinicians are part of this and that they understand the importance that open disclosure isn't about them giving information to families or patients and therefore feeling satisfied, but it's answering questions. It's informing the patient and family about what happened and why. And finally, you can't say sorry without it being meaningful. And so our contemporary open disclosure is about meaningful saying sorry. Open disclosure in the AIHE program is part of our patient-centered incident management, because open disclosure is about patient-centeredness. It's about the patient and their family understanding what happened and why, and being apologised to when appropriate. And the final arm that we have is our data-driven clinical governance. Everyone measures data, everyone's got KPIs, everyone knows their falls rate, everybody understands that these are publishable, but yet we just simply can't move the dial in improving these. We don't simply seem to be able to get any traction in key areas. What does the hand hygiene rate really mean when we measure and report it to the board? It's never 100%. Are we saying that we fail? Are we saying that we'll keep working on getting people to wash their hands? Will we do the data better? And yet we don't correlate it to hospital-acquired infections and demonstrate a real change one way or another, depending on hand hygiene. We don't use the data to analyse our clinical services, even if they're going well, to determine what could be improved. We don't bring that data together, integrate that data, triangulate it from different sources, and get a true analysis of a clinical service. Taking the clinical incidents, the complaints, the length of stay, the revenue data, the patient satisfaction, staff experience and satisfaction, bringing it together. We struggle every time there's a clinician poor performance to be able to measure that performance of the clinician's outcomes, because we simply don't have the data, and we spend more time arguing that the data is wrong than we do about how we can improve the physician's performance. And ultimately, the clinical outcomes need to matter to the patients and their families, not what we think is important. And if they're not truly engaged, then we can really be looking at data that is of very little use. So we take you to the case study we're on to briefly go through tonight to demonstrate the AIHE process. And this case study is of a gentleman, and these are all true case studies we use at AIHE and we use with permission. We've changed some of the things for privacy, of course, who is having chemotherapy as an inpatient, gets chest pain. There's a concern it might be an infection. The ECG is done. 2 hours afterwards, he suddenly collapses and dies. It's thought at the time that it was an unfortunate coincidence that it occurred in hospital, but his death was due to the underlying cancer. However, 2 weeks later, it was identified that the ECG, when it was looked at, showed an acute myocardial infarct. And it was subsequently found that the ECG was sitting on the desk for the 2 hours that patient was suffering with chest pain. And it had been reported by an external agency, which had said, the external cardiologist, that there was a heart attack. So how would your hospital handle this scenario? How would you actually go through when 2 weeks after the patient has died, the patient has been buried, that you determine that this has occurred? So we'll ask you the question, and this relates to mortality review. Thank you for that. And we'll talk then about how the case was managed. So thank you for your questions. In the next slide, we talk about what would you have done in your hospital, as I said, in this scenario? Who would have taken the lead? Were the clinicians working in scope? We talked about that earlier. Well, indeed, in this case, there were junior doctors who had not looked at the review of the ECG. The ECG had been reviewed by someone, but they hadn't thought that it was necessary to escalate it to anyone. The nursing staff had known the ECG was done, but hadn't tracked back to see if the ECG result was available, and the ECG result was sitting on the desk and no one had seen it. Clinicians who were engaging with the patient didn't know that the patient had been suffering pain and that was being investigated until they collapsed and died. The mortality review process it was done 2 weeks later, but there was no initial review, as one would expect, and within the first 24 hours at a team-based level, notwithstanding that the patient death may have been due to cancer, to analyse whether or not the death was preventable. That would have identified the circumstances early on. Now it was in position of an incident management having to be undertaken and a root cause analysis and an investigation into what happened. But the big question was, what are we going to do about it? How are we going to undertake the open disclosure? Has this happened before? Have we measured any outcomes for in-hospital myocardial infarct? And do we actually know how myocardial infarctions in hospital, when they occur, are managed? And attest to the culture of the staff and patient safety with regards to how they were responding under very stressful circumstances in this real case. So we'll ask you now what would have occurred, in your view, in your hospital with regards to this case in the next step. In your hospital, when you investigate a clinical incident, who's involved? And when an incident involves, how the open disclosure occurs. So strong response for everyone involved in the incident are able to contribute to the investigation. And a strong response for, I know what the open disclosure process is clear to me and I'm involved as appropriate. Very good. So in this scenario, the decision with regards to the patient, how to manage the incident and the open disclosure. So we'll move to the next slide. Taking the patient-centric incident management, in this case, the patient's passed away, therefore the patient equals the family. It's an opportunity for all of us as healthcare leaders how we respond 2 weeks down the track. Because the argument I make and AIHE we make is that patient-centered care is a standard. It is relatively straightforward to provide good care when things go right. The real test of whether or not we're providing patient-centric care is when things go wrong, is when things don't go the way we want them to. And if that occurs, then we're tested, our systems are tested, and we as clinicians are tested, and we as leaders are tested. And therefore, how we respond in those circumstances is a real test of our clinical governance framework and indeed of ourselves. So on the next slide, the approach we take here is, and I'll lead you through these, what's immediately going to happen? Well, an immediate decision is about who's going to take the open disclosure, when the family is going to be told, and the information that's going to be provided, how the clinicians involved in the case are going to be spoken with, counsel, and discuss how the case occurred 2 weeks later. They're not even aware of this finding. The commitment to transparency and openness with regards to the entire incident, notifying the coroner because the death was unexpected and indeed preventable, and ensuring ongoing communication with the clinical team, with the patient's family once we've made that call and undertaken the open disclosure, and with regards to the ensuring that right now, not another patient is harmed. The immediate action of ensuring that the cardiology group make sure that that result, if it's abnormal, is immediately provided to the clinicians, not wait to the end of the incident to management and investigation to come back and say, oh, we need to make a change in how we report back our ECGs. Make sure that right now there's a streamlined process in place for people with a myocardial infarct and how they're going to be managed in our hospital. And in our next slide, which is about the open disclosure, we might have answered that question, Sydney, so I'll just double check. Yeah, so we can actually, we've answered that one, so we can move on to the next slide. In our contemporary open disclosure, and in this particular case, the decision, and there was discussion about who would undertake the disclosure and how. And the Chief Medical Officer of the hospital said, this is such a serious case. 2 weeks after the event, we found this significant preventable cause of this death, that the open disclosure would be led by a senior leader. And in fact, the family, when contacted, determined where and when this open disclosure would occur. From a patient-centric perspective, this is critical. In fact, it was occurred at their home, at their kitchen table, with ECG in hand, prepared to say sorry for what had occurred and to explain the circumstances and to ensure the family were involved in the investigation. They liaised with the investigating lead of the RCA. They had a liaison person that could connect them with the investigators throughout the process, that their questions and their concerns were incorporated into the investigation. There was a commitment that they would get the full report, not a didactic reported subset of the report, but the full report, and that they could be involved, not just at the beginning and not just be told at the end, but through the process. So as information was becoming known, they could actually develop their questions and concerns and continue to raise them. And finally, that whatever those reports were, there'll be a commitment to improvement. So thank you. In this part, we're looking at the using of the data. And in this particular case, the question is how we're performing and how is data used in our organisation from a patient safety perspective. And do we share, the first one, do we share clinical outcomes such as falls? Do we have patient stories? You can use as many of these as you wish. There's no only one right answer, of course. Do they involve us in clinical incidents and the review of incidents, etc.? So we're getting some interesting spread of answers coming through now. Thank you for your responses there. In this particular scenario, using it as a case example, we're able to undertake the review of the acute myocardial infarct pathway, measuring the time it took for patients to get to the cath lab when they're an in-hospital patient, looking at the data that we obtained about the program of the care of patients in this scenario and openly discuss that with the clinicians, understanding that some of the things that we saw were quite troublesome and of course could be quite stressful, in particular, the harm to patients that occurred when the program doesn't function as well as expected or indeed isn't even triggered. Looking at benchmarking internal and externally, internal within our hospital group with respect to how this is undertaken in other hospitals and whether or not we can learn from those and make changes of improvement, and then benchmark externally about how similar hospitals undertake this type of work. And then determining what will be the actual targets of change, what those change would be, and how the data would then continue to be measured and the data would be acted on. And from there, the data would show improvement. One would hope, if the program works, but be able to be agile enough to pivot in the circumstances where it's not, and consequently be able to improve, change process, and be remeasured again. And all of these changes and the data were shared with this family. The family were involved not only through the incident management process, not only through the open disclosure, but indeed in the improvement program, and could see the evidence of improvement to the point that the facility became an exemplar in terms of the management of in-hospital acute myocardial infarction. So we'll go to the next slide, which is the summarising, coming back to what we said at the very beginning. We said, how do you know if your hospital's safe? How do you rest easy at night thinking through whether your hospital is undertaking the right care? How do we know that the systems are in place for our patients that keeps them safe? How do we know that our doctors and nurses and allied health and other clinicians and our support teams are working in an environment where the culture promotes safety? Well, I come back to these 5 points as being really critical. Let's refresh them in this case. The clinician scope of practice. Well, there weren't any cardiologists available. There were junior doctors. There were people who were less familiar. It's a cancer ward. They were doing their very best, but there were processes in place to support them. There was an ECG system available. There was an ECG reporting system available. Good clinical handover would have taken a part and it's made a significant change. Going back to the patient and checking with them about how they were feeling and reassessing the patient and understanding how the patient's symptoms were evolving. Escalating those concerns that they haven't been addressed. Patient ongoing symptoms for 2 hours being unmanaged, thinking that a set diagnosis of infection. All these things are part of clinical practice. It's not just about whether or not a person can do a particular procedure, but the clinical skills of analysing a patient's clinical status, determining differential diagnosis, and implementing care. The mortality review process. Had this mortality review process been in place in terms of involving the clinical team at the very beginning, early on following the death, really sitting down as a group and saying, let's have a look at this patient's death. It wasn't expected, and actually looking at all the circumstances, not just writing it off as a cancer death. It was going to happen. It's a shame. But in doing so, in that first level of mortality review, which can then escalate to the next level when identified, and it would have, that an ECG had been done, had it been reviewed? No, it hadn't. Here's the ECG. Oh, it's abnormal. Would have enabled not only to get the open disclosure and the incident management immediately done with the family, so they weren't 2 weeks down the track, but also the immediate actions to avoid further harm, getting those ECG reports coming through efficiently, particularly when there has been an abnormality, and ensuring that the teams could identify something that was not common, an in-hospital infarct, and trigger the appropriate response. In the clinical incident management, we saw in this case the importance culturally that the senior leaders say, we're going to undertake an incident review, not for the sake of the review itself, because it was required of us, not to comply with the legislation or the regulation from one of the agencies, not because we're supposed to do it because it's a SAC 1 or an ISR 2, but because the patient and their family require us and deserve us to do so. And then, in terms of the conduct of the clinical analysis and review, what were the outcomes we're reviewing, and were they meaningful, and how we would measure them and how we improve them. And in this scenario as well, the actual culture of patient staff survey of staff safety, because in here, if the culture of safety was about trying to escalate concern, looking after our patients, actually understanding that we have got concerns, that where to go to with those, that patient harm may not have occurred in the first place, but certainly the learning environment would have been one, instead of how can we avoid the difficult conversation with the family, how do we avoid scenario which looks and feels terribly confronting, to one about focusing back on the patient. And so on this slide, this is the AIHD reference, that patient-centeredness. We don't shy back from that. The fact that immediate actions are critical to the response in clinical governance, that you set the tone of how you do your clinical governance by how you interact with your teams, how you interact with the executive, how you interact with the board, and how you set the tone, whether it's in the operating theatre or at the bedside handover or in the emergency department. And that a tone of approach, one that is encouraging engagement with patients and family, encouraging escalation of concerns, encouraging people to contribute to reviews, and encouraging open and transparent dialogue with patients and families where things go wrong. And to move away from compliance focus, move away from client and moving away from compliance focus and from clinician focus to a patient focus. And then finally, making those changes and outcomes actually meaningful and bringing them into light in your organisation. Thank you, Sydney. So we've got to expand on our program in clinical governance. We've developed a masterclass, which we're putting our first one in April the 12th, a 4-hour masterclass about actionable clinical governance, where we take each of those 4 themes and develop them further using case studies that we've provided for the attendees, and also those who in attendance wish to share any of their own case studies, and work through together how we can use the framework of how we know our hospital's safe, and also the framework of our program with regards to our practical clinical governance in a manner that allows those who are attending to really get a deeper understanding of each of those components and how they can incorporate it into their clinical practice, whether they're a clinician, an executive, a board director, or indeed a patient. And you can follow us both on LinkedIn and go to our website, where you can see our resources there with regards to industry insights, leadership series, and what's happening on the horizon scanning, including our work on the AI space, and enroll in any of our events that are coming up into the next few months. We'll be at the APHA conference in April. So if you're attending there, we'd love to meet you in person. So we'll be talking through about our programs more in depth, and we'll have further material available. We encourage you to go to LinkedIn. Virtually every day we're posting in this space with regards to clinical governance, healthcare leadership, and professional development, and also to our website, which has got a whole range of resources and information available to you. Thank you very much for your attendance.
We might, we've got 10 minutes left, so we might open it up for questions, if that's all right with you, Lewis.
Yes, of course. Happy if anyone's got questions to
feel free to
put them into the Q&A, perhaps, Sydney?
Yeah, no, I've unmuted everyone, so should be able to ask any questions. Does anyone have any questions they want to raise? Or any scenarios, I guess, or challenges in your own
Thomas,
healthcare service?
I can see your hand up. I hope you can hear me. What's your question, Thomas?
Thanks, Dr. Chandrasekaran. Thanks, Prof. Prado. I think something that stood out for me is that concept of triangulation, and I wondered if you could expand on that a little bit further, because I understood it to mean that you have some data at hand, which are your known knowns. You've got your usual culprits, which you want to find out about, and then there's that team-based effort to come up with the other unknown unknowns. But I'd like to hear your take on what it means to triangulate in practical clinical governance.
Yes, thanks very much, Thomas, and thank you for the question, because it transforms what we've practiced in clinical governance from very well-meaning people, as I said earlier in the presentation, undertaking reviews, producing papers, organising meetings, great data being presented now on Power BI, wonderful information. But most of it, if you're at a board level, doesn't actually tell you and paint the picture. And if you're at the practical level of an executive or a healthcare leader, actually tell you what is wrong, if anything. Yes, if your falls rate's going up or your pressure injury rate's going up, it may give you some insights. But the triangulation of the data is really what the AIHE program does, because there is rich data at the hospital level, but very rarely is it brought together to give a meaningful picture. So I'll give you an example that explains this, Thomas, that in the way you've asked. If you're looking at a program and trying to assess whether your program's safe, let's take total knee replacements and orthopedics. You've got concerns. You've got a couple of hospitals and there's variation on infection rate, but you really don't know why, and you really don't know to what degree it's meaningful. Someone tells you there's a concern. You hear it about an infection control meeting. Yes, you go and get some data from somewhere that tells you this is what we think the infections are. But alone, that doesn't really tell you very much of what you should do. So in that scenario, we would look and say to your team and come to you and go, like, let's get the data that can be brought together. Let's look at individual clinician data. And here's a range of outcome information that we would need. Operating time and how long they take to do a total knee. Whether or not the operations and the patients go to ICU. Whether or not the length of stay is 3, 4, 5 days, whether or not the patient comes into the hospital a day before, whether or not they're using the same prep as recommended, whether they use the antibiotic prophylaxis as recommended on the clinician. Yes, some of those things are intuitive. Maybe you already know about the antibiotic prophylaxis, but often people don't think about the operative time. But even a visual look at the operating theatre to see that, in fact, in the hospital where the infection rate's higher, the doors to the theatres were open more often than not than doors in the hospital whose infection rate was lower. And that only comes from a combination of that information with your incident management data, whichever system you use, such as RiskMan, for example, with your coding data, which coding data and incident data rarely are equal, but they give you great information from a different perspective on the same type of problem. Benchmark data from, in the case of the scenario I gave you, which is the Australian Joint Registry. Internal benchmarking data, you can compare service lines at different hospitals for the same procedure and the same doctor working at different hospitals, or the same, all the doctors working within the hospitals. Paint that picture, including referral to rehab, age brackets of the patients, comorbidities. and bringing that information together. And we've undertaken this exact example. What we were able to determine was the scope of practice of one of the hospitals for orthopedics was too broad. Many of the doctors weren't doing sufficient numbers of cases to actually warrant continuing practicing. The hospital itself didn't do enough cases to warrant it. There was too much interference into the operating theatre with the doors being open, because we actually had an observational audit. There was cases were prolonged and being done in the evening with referrals to ICU to avoid complications being a problem at overnight. And then finally, a great reliance on days before admission and a prolonged length of stay, which resulted in cost to the hospital system as well as poor patient outcomes. A change then was initiated in terms of some of those criteria in discussion with the doctors, where we saw a reduction in those doctors who were doing low cases, a consolidation of everyone's clinical practice against clinical best practice, a reduction in interference into the operating theatre, a rescheduling of the theatre times, and a review of patients being admitted the day before surgery. And a combination of those saw a reduction in the infection rate to acceptable levels and an improvement in the revenue, the WOW, the cost base as well, because the patients were, of course, not getting infections. Had we not done an approach like that, it would have been easy to either blame one person or try and target one response without getting a true understanding. To know how to do that, you really do need to know where all the data is available, how to bring it together and bring it together in a meaningful way and get past that first barrier, which is the data is wrong. And I'll say this, having been a doctor for 38 years, my hospital, we look after sicker patients. The most common refrain we get in medical administration and clinical governance is our patients are different. Well, in fact, if everybody's patients are different, that's actually what's unique about them. And that's also what is the same about them. So moving past that to triangulating useful data. I hope that helps, Thomas. We go in depth with that in the workshop because we really think the data driving clinical governance is a game changer. People have tried to do it, but how you can do it meaningfully and how you can actually assess your clinical services and clinician performance, the same philosophy for both of those, is quite important.
Thank you, Lois. We might have to wrap up there because we've reached 7 o'clock. If anyone does have any further questions, feel free to reach out to us through any of our channels, through the LinkedIn or through the inquiries in our website. And if you check out the events page, there's a couple of new ones coming up, and there will be more added in the next few weeks as well. So we hope you've enjoyed it, got a little bit of a taste for what it is that we're offering, and we hope to see you at sign up to some of our future webinars and to have more open discussion about the issues that you face. Thank you, everyone, and
thank you very much. Good night.